guests, professors and members of Association of Physiologists of Tamil Nadu, administrative members of Trichy SRM Medical College, and enthusiastic delegates from Department of Physiology and Trichy SRM Medical College and Hospital Research Center. I, Nithila and Asmita, first year MBBS students, welcome you to Day 2 of ReAPTrocon 2023, a national conference on recent updates in reproductive physiology.
We have an exciting lineup of speakers and sessions ahead, all aimed at exploring the latest breakthroughs and innovations in the field of reproductive physiology. Before we begin, let's take Trichy SRM Medical College Hospital and Research Center who have made this event possible. Now, without further ado, let's dive right into the enriching sessions lined up for today.
Our first speaker, Dr. K. Meganathan, a distinguished consultant urologist and andrologist from Tanjavur, will be shedding light on a critical topic, management of male infertility. His extensive expertise in the field promises to offer invaluable insights, the subject of immense importance. Please join us in welcoming Dr. K. Meganathan to the stage. We also invite Dr. B. Adikesavan, Professor and Head, Department of Physiology, Tiruvannamalai Medical College, and Dr. Pramila, Professor of Pathology, Trichy SRM Medical College Hospital and Research Center, to chair the session. Dr. Dr. K. Meganathan has completed MBBS and MS at Tanjavur Medical College, received DNB in General Surgery in 2003, did MCH Rheology between 2003 and 2006 at Madras Medical College. He did his training at Pediatric Urology at the Department of Pediatric Urology at the Institute of Health, Chennai in 2002, did basic and advanced laparoscopy training in urology at MPUH, Nadiad, obtained microscopic andrological training from the Andrological Society of USI. He is now working as a consultant urologist at Vinodhagan Memorial Hospital since 2007. He is director of Sri Hari Urology and Fertility Center and director Alpha Robotics Surgical Center. He's also doing endo-urological professors like PCNL, RIRS, TURP, and laparoscopic urological procedures like radical partial nephrectomy, radical cytectomy, and transplant program in SB Hospital and at Tanjavur Medical College. He has also received Dr. K. Shivaraman's gold medal for MS in 2002. I think this certainly deserves a big round of applause.
Good morning, chairpersons. Good morning, respected delegates. First of all, I want to thank the organizers, the Physiology Department, SRM Medical College, for inviting me to speak about a common man's dream of becoming a father, how to evaluate and management. As we all know, the definition of infertility. So infertility is defined as the inability to achieve the pregnancy after 1 year of regular unprotected sexual intercourse. This was previously mentioned, but recently it's changed according to the age of maternal and also paternal age. So if the female's age is more than 35 years and male, even 6 months of unprotected sexual intercourse with the inability to achieve pregnancy, so they should evaluate for the management of the infertility. So infertility is not only it's the personal problem, is linked to several emotional, physical, and socio-cultural problems. WHO estimates around 60 to 80 million couples worldwide affected from this infertility. That is around 8 to 12% of the couples worldwide. But estimates in our populations in India, it varies from 3.7 to 15% according to the area of locations. Coming to the male factor. So male factor accountability is around 50% among the infertility patients, and male factor alone is around 20% of the infertility. So what are the things that will predisposing or increase the risk factor to develop the male factor in infertility? So most important is the advanced paternal age and lifestyle factors like increased use of drug abuse and sedentary lifestyles, obesity, smoking. These are all impact the male's fertility and also sexual health. So this is worldwide distribution of the infertility, and especially due to the male factor. Among the Asians, it's around 37%. So in next 30 minutes, I am going to discuss in the following headings. That's male reproductive system, office visit for the patient with the infertile couples for the evaluation and management of male infertility, and genetics in the treatment and evaluation of male infertility, and male endocrine dysfunction, male reproductive and sexual health, and the certain conditions that will affect the male fertility, and role of nutraceuticals and micronutrients in the management of idiopathic oligoasthenospermias, and management and evaluation of azoospermia, whether it's obstructive or non-obstructive, and management of varicocele, and assisted reproductive techniques, and sperm retrievals for the assisted reproductive techniques. And I will brush up certain things here about regarding the semen cryopreservations. As you all know, the testicular functions, that has got dual functions. It has got spermatogenesis and the hormonal synthesis. There is a testosterone synthesis. So these are all maintained by the hypothalamic pituitary axis, which is maintained by the luteinizing hormone and follicle stimulating hormones. Luteinizing hormone stimulates the Leydig cells to secrete testosterone, and the follicle stimulating hormone stimulates the Sertoli cells for the spermatogenesis. This is the morphology of the sperms. Most important thing is the head, which contains in the tip there is a acrosomes, which contains the hydrolytic enzymes, which is mainly meant to dissolve and entry penetration into the ovum. And the middle piece, which contains the mitochondria, which gives ATP and energy for the motile sperms and motility to reach the site of interactions, and tail, which facilitates the movement. This is the normal morphology of the sperms. So as we have discussed, the male reproductive hormone axis, which depends upon the hypothalamus pituitary axis by the luteinizing hormone, and the FSH, which is stimulated by the GnRH. Coming to the office visit, if the patient with the infertility came for evaluation of the male component of infertility, so most important things that we have to ask the history. There's a comprehensive reproductive history and sexual history. So we have to ask for the coital habits, frequency, and erectile status, and also the ejaculatory status. But then there is any history, any contradictions regarding the sexual habits, so we have to teach what are the correct methods of sexual habits, and when to have the coitus to have a good reproductive life. And in the past history, we have to ask for any childhood conditions that predispose to the male infertility, like retorquidisms, hypospadias, or orchitis due to mumps, or any viral illness that causes orchitis. And especially, we have to ask for the treatment history. Some patients might have chemotherapy for the childhood tumors, and which may not be revealed during their past history. So we have to ask specifically for that. And in the family history, we have to ask any siblings positive of infertility, treatment for infertility, and genetic disorders like cystic fibrosis or Klinefelter symptoms among the families. And consanguinous is also important, some genetic disorders which run in families. So we can assess the female partner whether there is any recessive component is there that may transmit into their offsprings. And occupational lifestyle exposures. Chronic heat, uh, that's a professional exposure to the heat, which might increase the intrascrotal temperature, which might be the cause for the infertility or predisposing factor for the male infertility. Or occupational exposure of the benzene-based solvents, pesticides, and heavy metals. These are all poison to alter the sperm morphology and also motility and also count. Coming to the physical examinations, so now the most of the patients are obese, morbidly obese, more than BMI of more than 25, and their sexual habits and also the secondary sexual characters all mal-developed, not well developed. So these are the things to be looking before treating and evaluating the male's infertility. So genital examinations, you have to examine for the hypospadiac matters or any changes in the penis, any surgical scar in the penis, or any treatment for congenital anomalies of the penis. And you have to assess the testis epididymis, size of the testis, epididymis, whether there is any lesions or any tumors in the testis. And you have to palpate both vas, whether it's palpable or not, and also assess whether patient is having clinical varicose or not. Coming to the rectal examinations, you have to palpate for the prostate and seminal vesicles if it is palpable. So after clinical evaluations, you have to subject the patient for laboratory evaluation. So most important is the semen analysis. So with the semen analysis, only we can assess whether the patient is abnormal semen parameters, whether the patient needs further evaluation and treatment or not. In semen analysis, what are the things you look into? So first and foremost is the volume of the semen. If it is more than 1.5 ml, which is normal, so if it is less than 1.5 ml, so you have to assess whether there is incomplete collection or retrograde ejaculations or any obstructive component in the genital tract. Then assess the count, that is the number of spermatozoa per eye per field. If it is more than 15, it's according to the WHO recent criteria, it seems to be normal. If it is less than 15, it's classified into mild, moderate, and severe oligospermia. If it is less than 5 million, it's considered as a severe oligospermia. And motility. So motility, the motile sperms, if it is more than 40%, it's normal. If it is less than 40%, you have to look in for the progressive movement of the sperms. If it is more than 32%, it's normal. And morphology, according to the Kruger's criteria, there should be minimum of 4% of normal morphology, that is head, middle piece, and tail. So that should be minimum 4 to have a normal pregnancy. If it is more than 14%, the chances of pregnancy rates will be higher. And you have to assess whether the patient is having pyospermia or not. If pyospermia is present, you have to treat according to the culture report. You have to give antibiotics and anti-inflammatory drugs. And seminal fluid analysis, other test which is necessary, which increases the evaluation and management of the male infertility. That is a viable, whether the sperms are viable or not. Sperm functional testing can be done with using acrosomal reaction score and spermatosomal pellucida binding assay. Sperm DNA integrity is also most important if you are planning for the assisted reproductive techniques, especially the in vitro fertilization, by doing the tunnel assay. These are reference values according to the WHO criteria. If the reference value is more than the patient's value, it's normal. So a single report is necessary to label the patient as a normal fertile patient. So you can go ahead with having a normal sexual intercourse without any further evaluations. If the results are abnormal, at least 2 samples should be collected to confirm the abnormality of the semen parameters. The 2 samples should be collected with a gap of minimum of 3 months. That is a one spermatogenesis cycles, that is equal to 64 days. So we have to wait for another 3 months to take another test to confirm the abnormal semen parameters. So if you suspect some abnormality in the semen parameters, then the patient should be subjected for the further evaluations by doing the hormonal evaluations. Initial hormonal evaluation is the FSH and morning testosterone. These two are important to differentiate between the hypogonadotrophic and primary testicular failure. So when sperm count is less than 10 millions, you can subject the patient for the hormone analysis. If there is any alterations in the hormones, we can go ahead with the comprehensive evaluations by doing the luteinizing hormone, prolactins, estradiol, free testosterone, and sexual hormone binding globulins. To further evaluate, to diagnose the primary testicular failure and hypogonadotrophic hypogonadisms, and if there is any suspicions of hyperprolactinemia, you have to further subject the patient for imaging studies. Coming to the imaging, so Doppler study of the scrotum is only to assess the testicular size, because it's already clinically evaluated scrotal examinations. So we can have supportive evidence by doing the Doppler imaging, by assessing the testicular size, any lesions, and assess the grading of varicocele. That should be confirmed of the clinical varicocele. So the treatment of varicocele depends upon only with the clinical varicocele, not with the Doppler study. Coming to the TRUS, the transrectal ultrasound, it's not indicated in all patients with male infertility. Low volume, that too we have excluded the inappropriate collection and retrograde ejaculation. Then you can subject the patient for transrectal ultrasound to assess the seminal vesicles. The diameter of the seminal vesicles should be assessed. If it is more than 1.5 centimeter, it indicates there is obstruction in the ejaculatory duct. And you have to assess the ejaculate duct, whether it's dilated or not, and also assess the prostate, whether there is any agenesis or any malformations in the prostate. MRI brain, as already discussed, the assess imaging for the assess the pituitary or hypothalamic lesions when the patient is having hyperprolactinemia, that is more than 15 nanogram per ml, and with profound hypogonadisms, you have to subject the patient for MRI brain to assess any lesions in the hypothalamic pituitary regions. So coming to the genetic evaluation is indicated in all patients with severe oligospermia, that is less than 5 millions, and all patients with non-obstructive azoospermia, and clinical suspicion or evidence of bilateral absence of vas deferens. So what are the 3 things you have to do in genetic evaluations? One is the karyotyping. So most common disorder with the karyotypic abnormality is the Klinefelter syndrome, that is XXY, 47XXY. And you have to assess the Y chromosomal microdeletions, which is that is the azoospermic factor, which is present in the long arm of chromosome Y, which has got 3 components, A, B, and C. A and B is more important, so it should be done before proceeding with any patient subjecting for in vitro fertilization, especially before subjecting the patient for micro testicular sperm extractions. And CFTR mutations means is the cystic fibrosis transmutational restriction mutations, which is necessary in all patients with the suspicion of bilateral absence of vas or any feature suggestive of cystic fibrosis or any family history of cystic fibrosis. If there is any alterations in the CFTR in the male component, you have to work up for the female partner also, whether the patient is having carrier or not. If carrier, so you have to do the pre-genetic counseling and pre-genetic analysis of the embryo before transferring for in vitro fertilization. Coming to the causes of male factor infertility, a lot of factors are there. So, there are surgically correctable and non-correctable. Surgically correctable is if patient has had already undergone any vasectomies, we can subject the patient for vasectomy reversal by vasovasostomy or vasoepididymostomy, and surgical correction of varicocele by doing the microscopic varicocelectomy. And if the patient is having any hypogonadisms, we can replace but that don't cure the male infertility, and it can improve the spermatozoa count or morphological or spermatogenesis within the testes. We can subject the patient for in vitro fertilization later onwards. And genetic, as already discussed, and lifestyle modifications. So lifestyle changes are very important in the treatment of the male infertility. This is the first and foremost in the treatment of male infertility, because most of the patients are obese, more than 25 BMI, with mostly sedentary lifestyles. And also they are mostly abusing the alcohol, smoking, marijuana, opiates, and multiple drug abuses are going on in the society. So these are all predisposing to the sperm alterations and male factor infertility. And idiopathic infertility is accountable around 50%, so which can be managed according to the semen parameters and hormonal changes. We can manage with the assisted reproductive techniques or medical management. So as already I told, lifestyle and environmental factors in male reproductive health. So obesity and sedentary lifestyles and stress, these are all important factors and cause for the male factor infertility. And increased use of smoking, alcohol, marijuana, and anabolic steroids, especially in the athletes and sports persons, which all decreases their reproductive and sexual health. Now the most important environmental factor is the cell phone use. Whether it will reduce the sperm motility or not, it's a question mark. So there is no prospective randomized control studies to confirm the effect of radio frequency electromagnetic radiations on sperm and testicular functions. There are a lot of in vitro studies which proven there is decrease in the sperm motility and spermatogenesis, and also the testicular hormonal function also. So increased cell phone usage, it's now considered as the predisposing factor for the development of the male infertility, not only male and also the female infertility. So these are mainly due to the increase in the intrascrotal temperature, and which in turn decreases the spermatogenesis and morphology and testicular hormonal functions. So any inflammatory conditions, any infections in the genitourinary tract. So these are all things can predispose to male infertility by producing the reactive oxygen species and anti-sperm antibodies and cytokines, which in turn produces oxidative stress. So what are the outcomes of oxidative stress? So previously the physiological effects of oxidative stress is also there. When there is low levels of oxidative stress, which in turn increases the stimulates the spermatogenesis. But increased dose of the oxidative stress, which in turn causes the pathological changes in the sperms, especially in the protein damage, lipid peroxidation, biomembrane damage, and DNA damage, which in turn causes the sperms and sperm DNA damage, and in turn leading to infertility. So a lot of causes for the oxidative stress. Most important is the smoking, pollution, varicocele, drug-induced, and any genital infections, which in turn causes the increase in the inflammatory and cytokine production, and also increases the oxidative stress. This is a recent article in Cellular and Molecular Life Sciences, which clearly demonstrates the oxidative stress and male infertility. It's now considered the main cause of male infertility, despite the need for the low levels of reactive oxygen species for the physiological function of the sperm. Increased level disturbs the sperm functions, thereby leading to male infertility. Early diagnosis of the infertility is necessary to prevent the irreversible damage due to the oxidative stress in the long term. Besides the lifestyle changes, the primary action to balance the levels of the reactive oxygens and antioxidants and oxidative stress. And then the smoking and alcohol, exposure to radiations, these are all predisposing factors which can be reduced to reduce the levels of oxidative stress to the sperms. And oral antioxidants. So nutrition supplements, whether it reduces the oxidative stress or not. Yes, it reduces the oxidative stress by producing the antioxidant, increasing the antioxidant capacity and also stimulates the uh, damage due to the decreases the damage due to the oxidative stress. So in turn improves the sperm parameters like motility, morphology, and also decreases the DNA damage. Further, overall fertility potential also improved. So what are the nutritional factors? So L-carnitine, coenzyme zinc, arginine, vitamin B12, and free radical scavengers like lycopene, vitamin C, E, glutathione, and selenium. So these are all proven factors which in turn increases the spermatogenesis and sperm functions and also the reproductive health. When there is deficiency of these, can lead on to the alterations in the semen parameters and infertility. So there are two studies which correlates the usage of levocarnitin in idiopathic astenospermia. There's the Italian study group which studies in 100 patients where they give 3 grams per day for 4 months. So after 4 months, they assess the sperm motility, which increases from 26 to 37%. And also the total number of spermatozoa per ejaculate is also increased. Another study by Costa et al., which shows the L-carnitine increases the spermatozoa with rapid linear progressions, which is more important for the increase the conceptions. Increases from 3.1 to 20%. And also there was significant improvement in the sperm count, motility, and also pregnancy rates in patients with due to the varicocele. So another one is a coenzyme Q10. So this is a naturally occurring compound in every cell of the body, which is also known as ubiquinone, found in foods, fish, and meats. It's mostly concentrated in the mitochondria of the midpiece, so which gives the energy-dependent process in the motility and also the spermatogenesis. So deficiency can result in sperm damage, lower the sperm motility, and also count. So this is responsible for the energy for the movement and all other energy dependent process in the sperm cells. And another one is the melatonin. This is recently researched well in the treatment of male infertility, which is normally produced by the pineal gland, which maintains the sleep-wake cycle, that maintains the circadian rhythm. So it's widely studied in various management modalities, say especially in the male reproductive health and also female reproductive health. It has a potent free radical scavenger activity with subsequent antioxidant and anti-apoptotic function. It has got indirect action as antioxidants through the activation of the endogenous antioxidant enzymes like superoxide dismutase, glutathione peroxidase, and catalase. So there are a lot of clinical evidence to show these nutritional supplements can be used as a nutraceuticals for the management of the male infertility. The coenzyme Q10, as already discussed, it improves the sperm parameters and oxidative stress markers and sperm DNA fragmentation in infertile patients with idiopathic oligoasthenospermia. So these studies, which gives clearly that there is increase in the spermatogenesis and sperm function, which can be used in the treatment of idiopathic infertility or oligoasthenospermia patients. So the concluding that studies, this coenzyme Q10 can attenuate the ROS effects and enhance the sperm functions, and also affirms the supplementation coenzyme Q10 for the duration of 3 months, decreases the sperm DNA fragmentation, and improves the semen quality. So these various studies to have the clinical evidence to give these drugs, these as nutraceuticals for the treatment of management of the infertility. And melatonin is recently widely studied in teratospermic and also azoospermic patients. So this can be used in the treatment of male infertility, which increases the sperm motility and decreases the oxidative stress because it acts as antioxidants. It can be added to the patients, those who undergone varicocelectomy. So sperm count and percentage of motile spermatozoa and proportions of normally formed spermatozoa is also increased significantly in patients treated add-on to the benefit to varicocelectomies. So there's a conclusion of these studies. There was significant increase in the total antioxidant capacity in the melatonin group compared to the placebo. And lycopene, when it given in 2000 microgram twice a day for 3 months, it's studied in 30 patients, which concluded significant improvement in the sperm concentration, motility, and morphology. So it acts as prevents oxidative damage to the sperms. So the nutraceuticals is widely studied, and now there is combination of the nutrients which can be used in the management, like coenzyme Q10, L-carnitine, lycopene, melatonin, which can be accompanied with the zinc, selenium, and vitamin A, C, and E. So these all act as the potent antioxidant, prevents the oxidative stress to the sperms and also spermatogenesis. But these studies they compared with the placebo, they didn't compare with the normal increased intake of nutrients. So that's a main drawback in these studies, because they are promoting the nutraceuticals as the pharma companies. They are promoting as a huge market in the treatment of the male infertility. But there is no comparative study with the normal nutrients in the diet, which can be increased, which also has the same effect as compared to the nutraceuticals. So coming to the male sexual dysfunction, so it should be evaluated during the course of the male infertility. So it should be asked, because the men rarely disclose these sexual problems to the primary caregivers. This is the most important cause of infertility. So what are the things you look into? The erectile dysfunctions, decreased libido, premature ejaculations, and orgasmic alterations. So these can be managed by asking the history, and also it can be treated according to the disease. Like we can give the phosphodiesterase 5 inhibitors with sex counseling for the erectile dysfunctions. If the patient is having premature ejaculations, we can give the SSRI, the serotonin reuptake inhibitors, and also sex therapy can be given for the treatment of premature ejaculations. So it should be the part of evaluation and the treatment of the male infertility. And coming to the specific medical therapy, so it's mainly indicated in hypogonadisms, hypogonadotrophic hypogonadisms. So we can give the HCG in the dose of 1,500 to 2,000 units 2 to 3 times a week for 18 to 24 weeks. So this can be assessed how the spermatogenesis, how much sperm count is increased or not. So before subjecting the patient for assisted reproductive techniques, also we can give this HCG to stimulate the spermatogenesis within the testes. And other drugs that are studied are the recombinant follicle stimulating hormones and human menopausal globulins. Testosterone replacement therapy. So it's not indicated if the patients are willing for sperm productions within the testes. So the sperm retrieval rate will be decreased if the patient is having treated with testosterone replacement. And another drug is studied is a clomiphene citrate, which can be used in the cases of adult onset hypogonadism. So which also there are certain studies which increase spermatogenesis, increase the count in cases of the adult onset hypogonadism. And anastrozole, so it's aromatase inhibitors, which increases the circulating testosterone and also decreases the estradiol. So it's indicated when the patient is having decrease in the testosterone with the increased estradiol levels in their blood. Then you can suggest to proceed with the anastrozole for 3 months. Then you can study the circulating testosterone levels and the estradiol levels. Then assess the sperm count also, which in turn increases the sperm. So these are all the medical management, the nutraceutical managements for idiopathic oligoasthenospermias. When the patient diagnosed with azoospermias, it has to be classified into obstructive or non-obstructive. So when you suspect obstructive azoospermia, when the follicle stimulating hormone is less than 1.6 milli-international units, with the testis of normal size, that is more than 4.5 centimeter, indicates there is normal testis with normal follicle stimulating hormones. That indicates it's a normal testosterone endocrine function and spermatogenesis. Not spermatogenesis, normal endocrine functions. So if the patient azoospermia with these, we can think in terms of obstructive azoospermia. So when the FSH level is elevated, or testicular size is smaller, so you can think in terms of there is decrease in the spermatogenesis, then maybe primary testicular failure. So which suggests non-obstructive azoospermias. So in azoospermias, next foremost important in obstructive azoospermias, you have to whether the patient is obstructions in any genital tract. It may be in the ejaculatory duct, which can be assessed if the patient is in low volume, fructose negative with the seminal vesicle diameter of more than 1.5 centimeter and large number of sperms in the cell. We can select ejaculatory duct obstructions. So with the ejaculatory duct obstructions, we can treat according to the disease. We can give transurethral resection of the ejaculatory duct and the obstructions within 1 to 1.5 centimeter from the virement. If the patient previously undergone vasectomy if the patient came with the prior history of vasectomy, is now willing to conceive. So these patients, vasectomy reversal is cost efficient in comparison to the in vitro fertilization and HC. So vasectomy reversal can be done by vasectomy or vasoepididymostomy, which is a microscopic technique. So it should be done with 80, 90 or 10-0 nylon. It should be leak-proof and tension-free anastomosis. So vasostomy has got good results in comparison to the vasoepididymostomy. Vasoepididymostomy needs more technical demanding. So it's very small. The diameter of the epididymis is around 150 to 250 micrometers. So it's very difficult to do even with the microscope. So the success rate with the vasostomy is around 30 to 40%. With the vasoepididymostomy, it comes around 16 to 25%. So if the patient success after vasostomy or vasoepididymostomy, so they can have a normal pregnancy in 20 to 30% of the patients. In all other patients, even after vasostomy or epididymostomy, the sperm retrieval rates is also increased because of increased spermatogenesis after the obstruction is relieved. So coming to the surgical correction, as already vasostomy, vasoepididymostomy, and one more surgically correctable disease that causes male infertility is the varicocele. So varicocele causes 35 to 40% of the infertile patients. That is mainly in the primary infertility. Around 60 to 70% in secondary infertile patients. So most important pathophysiology for varicocele that causes male infertility is the scrotal hyperthermia, which in turn lead on to the hypospermatogenesis. So these patients should undergo, if clinically diagnosed varicoceles, if it is larger varicoceles and bilateral, surgery is indicated. The surgical techniques can be variant. So you can do open technique or laparoscopic or microsurgical varicocelectomy. So microsurgical varicocelectomy has got a high success rate with low recurrence and less complications. So this is ideal for patients with male infertility with bilateral varicocele. So we can give better success rate and they can have a normal fertility after the varicocelectomy, which increases up to 40% after varicocelectomy. There will be significant improvement in the semen parameters, endocrine functions, and also increase the pregnancy rates and also increase the sperm retrieval even in azoospermic patients who undergone microsurgical varicocelectomies. So coming to the sperm retrieval techniques in assisted reproductive techniques. So how we can retrieve the sperms? So we can retrieve the sperms from the epididymis if there is obstructive azoospermia. If non-obstructive, we can do the aspiration from the testis. It can be TSR, that is testicular sperm extraction or aspiration. Testicular sperm extractions can be done with open surgical techniques or microscopic techniques. Microscopic TZ, that is more important, increases the sperm retrieval rate. It can be increased up to 60% even FSH is more than 30 and even in patients with Klinefelter syndrome. So we can give their own sperms for their in vitro fertilization. And most important thing is the genetic testing for Y chromosome microdeletion should be done in all patients before subjecting the patient for TZ. So as already discussed, intrauterine injection is the first line of management of the ART in patients with male infertility, those who are failed after surgical techniques or medical management. So it can be washed by swim-up or spin-down technique and incubated and injected into the uterus. And in vitro fertilization done with the using their own sperms, washed active sperms in patients with oligospermias, astinospermias, or tetraspermias. So you can give 50 to 150,000 sperms per oocyte. It can be incubated for 12 to 18 hours and get the embryo ready and then transfer into the uterus. ICSI is the intracytoplasmic injection of sperms with all metaphase 2 oocytes. So it increases the number of gametes and it can transfer into the uterus. The reasons, there are a lot of studies are going on for genetic diagnosis and pre-implantation genetic diagnosis. So which can be done before subjecting the patient for TC. So you have to do the Y microsomal deletions and genetic karyotyping. If you suspect any alterations in the genetic, so you can subject the patient for pre-implantation genetic diagnosis by using the single blastomere, which can be subject to PCR amplification. You can identify the affected embryo and also unaffected embryo. So unaffected embryos can be injected into the uterus. Like that, another one is the genetic screening using PGS analysis of single blastomere using the fluorescent in situ hybridization technique. So which is mainly indicated in elderly maternal age group and recurrent pregnancy loss and also failed previous techniques of ARTs. So these are the recent updates in the management of the assisted reproductive techniques. So small, I want to brush up the sperm cryopreservation. It's widely discussed in all patients in from childhood tumors to the any malignancy in the adolescent or adult age group, in the reproductive age groups. So what is sperm cryopreservation? So semen liquefied at room temperature and it's mixed with 12% glycerol, which acts as a cryoprotectant, which is vortex divided equally in vials and suspended in the liquid nitrogen for 15 minutes. There is liquid nitrogen vapor. Then it should be plunged into the liquid nitrogen, which is kept at minus 196 degrees Celsius, which can be kept to many more years as required. So this ideal, the time limit for keeping the sperms is the patient's reproductive age group. So that is the criteria for the time limit of keeping the sperms. The survival of the sperms should be assessed in after 24 to 48 hours of cryopreservation. We have to assess the sperm motility and viability of the sperms. Then only we have to keep it as in the cryopreservation. If it is not there, we have to once again subject the patient for sperm retrieval or sperm collections, and you have to do the cryopreservation. Sperm banking should be done for all patients with malignant disease who wish to have children. In vitro fertilization of the cryopreserved semen is equal to the fresh semen samples retrieved in terms of the pregnancy rates. But if it comparable with the normal pregnancy rates without IVF, without assisted reproductive techniques, it's lesser in compared to the fresh semen. But in vitro fertilization, it's equal. So what is the future in male infertility management? There are a lot of techniques, microarray technologies, which yield new diagnostic and therapeutic advancements in the management of the male infertility. So in future, patient may present with the genetic records, perhaps recorded in an embedded microchip, delineating entire genomic sequences, so which can be useful for our prospective evaluation of and genetic analysis of the patient. And management-wise, the targeted gene therapies is also in the work. So in future, it will come into the treatment of the male infertility. So on summarizing my talk, so male factor infertility is almost 50% of the causes of infertility. So it's most important in all patients with infertility or to consider the male factor infertility. So evaluation includes the sexual history, clinical examination of the genitalia, semen analysis, hormone analysis if indicated. Genetic analysis should be done in all patients with severe oligospermia and non-obstructive azoospermias, which includes the karyotyping, Y chromosome microdeletion, and CFTR mutations. Lifestyle, in the treatment, lifestyle modifications is the first and foremost. Reduce the BMI, reduce the smoke, Smoking, alcohol, marijuana usage increase the physical activity. And nutritional supplements, as already discussed, the coenzyme Q10, melatonin, carnitine, and zinc are added benefits in the treatment of idiopathic infertility and oligostenospermia patients. Hormone replacement therapy is indicated in patients with the primary or secondary hypogonadism, which can be given in the form of human chorionic gonadotrophin. And testosterone replacement therapy is not indicated if they are willing to have ART techniques. Microscopic varicocelectomy is indicated in all patients with clinically palpable varicocele with abnormal semen parameters with the confirmed infertility. And artificial reproductive techniques like IUI, in vitro fertilization, intracytoplasmic sperm injections indicated in non-obstructive azoospermia patients. Vasovasostomy, vasoepididymostomy is indicated in vasectomy, patients with vasectomies or obstruction at the level of vas deferens or in the distal epididymis. Transurethral resection of the ejaculatory duct is indicated in obstructive azoospermia with ejaculatory duct obstructions. So these are all surgical correctable causes of male infertility which can be corrected, and you can subject the patients according to the semen parameters after 3 months of study. Thank you for your kind attention. Thank you.
Thank you, sir, for the enlightening presentation. Now the forum is open for discussion.
So it's a very excellent talk about the pathophysiology of the male infertility. It's really very enlightening. So now only we are just knowing about the recent trends and the diagnostic field, and also in the treatable measures and correctable measures and preventable measures. It's very excellent. It is not only for physiology, it's for everybody, all the field. It's very nice, very enlightening talks. Very useful for all the youngsters and all the medical field, because it is male infertility, still it is missed, and it's very nice. Thank you so much. So any doubts, audience?
It was a very excellent, informative session, sir. We are clinging on to every word which you were talking. You were talking about vasovasostomy. You said that there is about a 30 to 40% success rate. We learned about anti-sperm antibodies following vasovasostomy. So what is your experience regarding it?
Anti-sperm antibodies is proven. If there is anti-sperm antibodies, you can be treated with the anti-inflammatory agents like NSAIDs can be given, and also we can supplement with all the antioxidants. So after that, we can subject the patient for vasovasostomy. Vasovasostomy in more the technical, so we have to cut the proximal and distal end. We have to assess the sperms. So whether the sperms is active, motile, then only you have to proceed with the vasovasostomy. The success rate of the vasovasostomy depends upon the availability and the aspiration of the distal one of the vas. If there is motile sperms, it can be, the success rate will be around 40%.
So is tubectomy a more successful procedure? Reversible of tubectomy a more successful procedure compared to vasectomy?
Yes. Compared to vasectomy, tubectomy reversal is more successful. Because the thing is, after vasectomies, even the spermatogenesis, endocrine function and also spermatogenesis functions both have decreased after vasectomy. That too, the prolonged period of vasectomy causes all the inflammatory changes within the testes, because the function of the testes becomes altered. So that's more important cause of the failure of reversal of vasectomy.
We're talking about melatonin as one of the factors which can increase male infertility. But today, due to the lifestyle changes, like I think all professions, there is night shifts, including IT professionals, added to the cell phone usage, the laptop usage, etc. And there's something called as light pollution as well.
Yes.
Even the various species are unable to reproduce. So In your experience, are there studies? Do we need some? The world itself needs some kind of a lifestyle change, etc.
Lifestyle
The workplace
changes is the
based.
must in all the field of medicine, especially in the reproductive and sexual health. It's more important. The lifestyle modification should be there. There should not be any sedentary lifestyle. They should be more active, and their BMI should be less than 25 to have a good sexual and reproductive health. So the cell phone usage, as you said, and laptop usage, these are all increases the incidence of male infertility, and also the ejaculatory, especially the erectile dysfunction, is increased among these patients.
So night shift should be avoided, particularly in.
So there is no exact studies which shows the night shift and day shifts. The circadian rhythm has been altered.
Okay.
So that's the main reason which in turn reduces the levels of the melatonin in the blood. So which maintains the sleep-wake cycle. So it's altered. Even in the night shift, they have to have a good sleep in the day. If it is maintained, there should not be any problem with the function of the melatonin. If it is that also altered, then they have to face the problem.
Think about alternate. Thank you, sir.
So good morning, I'm Dr. Hari Babu from Tirunelveli Medical College. So I just want to have some basic clarifications. So please shed some light on that vortexing of that sperm cryopreservation. How is it done? The second line of that sperm cryopreservation said something about specimen vortexed.
That means you have to separate. So you have to make it in the separate vials. So it has to be equally separated, the sperm, collected sperms. So equally divided and collected in the vials. That's the term. You mean the vortex?
Vortexing.
So it has to be division.
Okay. Any criteria for the division? So just
there is no specific criteria.
No specific criteria.
So that
preserved sperms.
Any number of years. There is no time limit for
time limit.
Still, the liquid nitrogen is present. If it is liquid nitrogen levels are decreasing, then only if temperature is increased, then only the cryopreservation will be failed.
Okay, so when we use a cryopreserved sperms for the DRT, do we have any other tests to assess the viability of sperms or to test the vitality of sperms?
Should be assessed even before subjecting the patient for cryopreservations. Sperm motility, viability should be assessed. Then 24 to 48 hours after cryopreservations, you have to take the specimen, do the testing. Then only you have to proceed with the cryopreserved sperms. See, if it is if 24 to 48 hours, if the cryopreserved sperms have got good motility and good viable sperms, it will be equal even at the end of even while taking the semen for ART is also the same.
Okay, so
it won't decrease.
Okay, so decreased motility and dead sperms, actually they are both completely different terms, I believe.
Yeah.
Because dead sperms we call it as necrospermia. And,
entirely different.
Yeah. How do we assess that the sperms are dead or alive, sir?
The viability test.
Yeah.
So if it is motile sperms or immotile sperms, if it is less than 5% motility, you have to subject the patient for viability test.
How do you do that, sir?
Its viability testing is available in all the technical. I have discussed all these things here. We can assess by giving that is acrosomal reaction assay, acrosomal reaction. So you have to assess the head. So acrosomal reactions you have to assess. That scoring is there. The SAR is there. Sperm acrosomal reaction scoring. So if it is good, that indicates it's a good viable motile sperms.
That was a wonderful presentation by you, sir. It was a detailed and informative. Each and every part you explained very beautifully. The genetic evaluation you told, what will be the cost? Whether the patients are affordable, have you come across?
Cost-wise, that it won't much as compared to the in vitro fertilization and HC. So it will be manageable only. Okay. So cost-wise, because it's available in most of the cities. dietocities is available. All the genetic analyses are available. So basic karyotyping is available in all the centers. So you have to subject according to the certifications. The micro deletions, Y chromosome micro deletions is indicated when you suspect in patients with non-abstract dysautonomia when you subject the patient for ARTs. So at that time they should be affordable to proceed with the ARTs. So they should affordable.
What's the role of trauma to testis? Have you come across any trauma to testis?
Trauma to testis, these are things, trauma, torsion testis, any surgical procedures in the childhood, these are all increases the antibodies to the sperms because it's the testis barrier is altered. So the antibodies will be produced to their own spermatozoas, it will be destroyed. So there will be even trauma, mild trauma won't produce any alterations in the antibodies. If there is trauma to the tunica and there is any hematocele, any damage to the testicular parenchyma, then there will be chances of anti-sperm antibodies. So it will produce.
Thank you, sir. Thank you. So I take this opportunity, Dr. Muhil and Dr. Muhil Madam and her team. I congratulate for organizing this program. Wonderfully, you have arranged for the part since yesterday, and today we are having this academic feast.
Morning, sir. My question is this: in your clinical practice, what seems to be the leading cause of male infertility, and how do you tackle it?
Because most of the patients referred by the gynecologist to me. So in my practice, more than 50% is idiopathic. So around 20 to 30% is due to varicocele.
So, how successful are surgeries for varicoceles in improving?
Microscopic varicocelectomy have got good results if the patient is having clinically diagnosed bilateral larger varicoceles. If it is unilateral varicoceles or grade 1 or 2 varicoceles, the success rate will be reduced.
Sir, and role of coenzyme Q, carnitine, generally in subnormal sperm parameters?
May have the role. I could not tell exact values of this. These are all studies which proven there is increase in the sperm parameters. So we can give as routine treatment for the time to take the exact management of the infertility. So we can give all the nutraceuticals, the combinations of L-carnitine. L-carnitine mainly meant for giving energy to the sperms, which increases the motility. And coenzyme Q10 is also same. It acts as antioxidants, and melatonin and zinc, selenium, all can have some role in increases the sperm parameters.
So you're talking about the commoners being idiopathics. So how do you essentially tackle that? We go ahead with IUI or XC?
So I will treat the patients with 2 cycles of spermatogenesis. That is 6 months of medical management. If there is no improvement in the semen parameters and there is no pregnancy, increase in the pregnancy, so I will subject the patient for next evaluations, and I also advise them to proceed with the ARTs.
Okay. So what medical management do you?
It depends upon if there is any decrease in the suspected hypogonadisms, I will give HCG. If I will give nutraceuticals as a supportive treatment for all idiopathic male infertility.
Thank you, sir.
Because we have to give time for the patients to think of and undergo the treatment of ARTs because it's costly. So,
We welcome our observer from Tamil Nadu Medical Council, Dr. Revathi ma'am. Welcome, ma'am. I request Dr. Muhil ma'am to felicitate our dean.
Thank you, ma'am. We invite Dr. B. Adikesavan to felicitate Dr. K. Meganathan with a shawl. Thank you, sir. Dr. Pramila with the memento. We invite Dr. Deepa Lakshmi to gift sir with a gift. Thank you, ma'am. We invite Dr. Etia to felicitate Dr. B. Adikesavan, sir. Thank you, ma'am. We invite Dr. Divya to felicitate Dr. Pramila. Thank you, ma'am. Following this, we have the privilege of hearing from Dr. Divya Sethuraman, a professor of obstetrics and gynecology, Trichy SRM Medical College, Hospital and Research Center, who will enlighten us on recent trends to overcome recurrent pregnancy loss. Her extensive knowledge and experience in this area are sure to provide us with valuable perspectives. Please join us in welcoming Dr. Divya Sethuraman to the stage. And also Dr. Vijay Devanand, Professor and Head Department of Physiology, Stanley Medical College, and Dr. M.R. Renuka Devi, Principal and Professor of Physiology, Sri Balaji Medical College and Hospital, Chennai, to chair the sessions. I request M.R. Renuka Devi ma'am to introduce Dr. Divya Sethuraman ma'am.
Very good morning to one and all present here. It's a great honor and privilege to welcome and chair the session on recent trends and recurrent pregnancy loss. As we all know that ReTU ends, it's a common problem faced by the logicians. On one side, the known cause, and the other side, the unidentified cause. So, Madam is there with us on the recent trends to overcome the recurrent pregnancy and carrying the caterpillar. So, she is Dr. Divya Sethuraman, Professor Department of OB, Trichy SRM Medical College and Research Center. She graduated from PSG Medical College and did her postgraduate from Madras Medical College. She has completed advanced course in medical education and is an active member of the medical education unit here. She has various publications at national and international conferences. Teaching experiences is around 11 years. Welcome you, ma'am.
Thank you, ma'am, for those kind words. I deem it an honor to be amongst such learned faculty, and I want to specifically thank Muhil madam for giving me this opportunity. Without further ado, we'll go into the presentation. So the objectives of my presentation today are to define recurrent pregnancy loss, to enumerate the causes of recurrent pregnancy loss, to list the investigations and the treatment of recurrent pregnancy loss. So a miscarriage is essentially a very traumatic event in the life of in the reproductive life of a lady. And a recurrent pregnancy loss, which means loss of three A recurrent pregnancy loss is defined as a loss of 3 or more consecutive pregnancies, and it affects 1 to 2% of women who are trying to conceive, and 1 to 2% of second trimester pregnancies, or essentially pregnancies after 12 weeks of gestation, will miscarry before 24 weeks of gestation. Going into the maternal age, all of you know that as the age of the woman increases, the quality of the oocyte becomes poor and her chances of conceiving progressively becomes less. The risk of a miscarriage is about 25% when she is 35 years of age, and this increases to about 95% when she is 45 years of age. So this maternal age is a significant reason for miscarriages. Coming to the number of miscarriages, when there are 3 or more miscarriages, there is a 40% risk that she will have another miscarriage. Unlike before, we are talking about advanced paternal age because studies show that semen quality decreases with increasing age of the male of the husband or of the husband. So the worst combination would probably be a female partner with an age of more than 35 years and a male partner with an age of more than 40 years. This has been proven to be an increased risk of recurrent pregnancy loss. Alcohol consumption is a known teratogenic agent both during pregnancy, and it also affects conception. Not many studies are there on maternal cigarette smoking and caffeine consumption, but these have also been implicated. Obesity is a separate risk factor for recurrent pregnancy loss. The one treatable cause of recurrent pregnancy loss that we face is something called an antiphospholipid antibody syndrome, known as APLA. What this means is you have antibodies which go and destroy the placental tissue, thereby increasing risk of miscarriage. Now, what are the antibodies which are implicated? We have 3 main antibodies, which are the lupus anticoagulant, anti-cardiolipin antibodies, and beta-2 glycoprotein. So these cause placental necrosis and thereby miscarriage. Now, what is the criteria for diagnosing APLA? You should have either one of the above criteria, which is 3 or more consecutive losses in the first trimester before 10 weeks of gestation, a single loss of a morphological normal fetus after the 10th week of gestation, or 1 or more preterm births before 34th week of gestation owing to placental disease. Now, what do I mean by placental diseases? These patients will either manifest as preeclampsia or hypertension in pregnancy with proteinuria, or they will manifest with intrauterine fetal growth restriction. How does APLA cause morbidity? It inhibits trophoblastic function and differentiation, which is very important for the setting up of the fetal circulation. It activates the complement pathway in the maternal fetal interface, thereby causing a local inflammatory response. And it causes thrombosis to the uteroplacental vasculature, thereby decreasing blood flow to the fetus and thereby causing miscarriages. Going on to genetic factors. Genetic factors are associated with recurrent pregnancy losses, more so when there is an increase in maternal age. The common genetic factors which is implicated in recurrent pregnancy loss is an unbalanced structural, unbalanced translocation seen either in the fetus, the mother or the father is a carrier of this translocation, and when transmitted, the baby is affected. The risk of miscarriage depends upon the size and the genetic content of the rearranged chromosomal segment. Aneuploidies, chromosomal abnormalities in the fetus have also been implicated in recurrent pregnancy loss, and this risk increases with increasing maternal age. Anatomical factors of the uterus, which is the arcuate uterus or the septate uterus, have been implicated in recurrent pregnancy loss. These are associated more with second trimester losses, which is usually more than 13 weeks of gestation. And the exact cause is not known, but probably problems in the implantation of the embryo is implicated in this. As you see, there is a wide range of incidence, meaning it is 1.8% to 37.6%. Now, this is because there were varying criteria for diagnosing it, and this came from different studies where they studied through 3 or more pregnancy losses. The next thing I'm going to talk about, what do I mean by cervical weakness is also taught as cervical incompetent. Now, this diagnosis is essentially based on history. So what do I mean by history? You have a patient who's in the second trimester who suddenly has a gush of liquid flowing between her legs. So essentially, she has sudden rupture of membranes in the second trimester, and there is painless dilatation of the cervix, resulting in expulsion of the fetus. So this is the classical history you will get in a patient with cervical incompetence, where there is sudden rupture of membranes, which is usually painless, and the patient expels. Now, the problem with this is we don't have any objective tests to diagnose this when she is not pregnant. So essentially what we work is, she has a history, and then we take it from there. Endocrine causes like diabetes mellitus is implicated. Now, when does well-controlled diabetes does not cause recurrent pregnancy loss, but uncontrolled diabetes with a very high HbA1c is implicated in recurrent pregnancy loss. Autoimmune thyroiditis is also known to cause recurrent pregnancy loss, where there's an increase in circulation of anti-thyroid antibodies. Polycystic ovarian syndrome. How does it cause recurrent pregnancy loss? Is because there is an increased risk of hyperinsulinemia, insulin resistance, and hyperandrogenism. So all these are implicated in recurrent pregnancy loss. This is, I guess, the most vague cause of RPL. Everything has an immune origin. Anything we do not understand, we implicate the immune system in that. And RPL is no different. What they say is there are 2 types of T lymphocytes. You have Th1 cell and Th2 cells. Now, the T helper type 1 cells produce pro-inflammatory cytokines like interleukin-2, tumor necrosis factor, whereas the T helper cells type 2 produce anti-inflammatory cytokines like IL-4/6/10. So when there is a discrepancy between both, meaning there are more pro versus anti-inflammatory cytokines, this has been implicated in recurrent pregnancy loss. The other factor is increase or abnormal function of the natural killer cells in the uterine milieu is also implicated, Both of these are extremely difficult to prove and treat. Coming to the infective causes, screening for TORCH, which is basically Toxoplasma, Rubella, cytomegalovirus, and herpes simplex, has been done for many years as one of the routine investigations as a part of RPL panel. But this is given up now. Why? Because for an infective pathogen to cause recurrent pregnancy loss, it should persist in the genital tract without detection. Number one, right? And should not really disturb the mother or the women. So both of these criteria are not fulfilled, as a result of which TORCH screening is given up as an investigation for recurrent pregnancy loss. Now, what is coming up is bacterial vaginosis. Now, what is bacterial vaginosis? Usually, a woman's vagina is colonized by healthy bacteria called lactobacilli, which keep the vaginal pH acidic. Now, this is normal. Now, when this is colonized by abnormal bacteria, the pH becomes alkaline. The woman develops a musty odor. She develops itching. So, this is called bacterial vaginosis, and these bacteria are essentially anaerobic. We have criteria for diagnosing them. Now, bacterial vaginosis in the first trimester has been implicated in second trimester loss and preterm labor. We don't usually screen for them in our setup, but maybe we should start screening for them in patients with recurrent pregnancy loss. Inherited thrombophilias. Now, inherited thrombophilias include factor V laden mutations, prothrombin gene mutations, hyperhomocystinemia, protein C and S deficiencies. Now, all of these are in some way involved in the coagulation cascade, and interference or a mutation in any of this causes thrombosis. Of this, these are essentially very rare. And amongst this, the most common is your factor V laden mutation. Now, the association with recurrent pregnancy loss depends on two things. What is the mutation that we are dealing with, and when does it affect the pregnancy? Now, this factor V laden and prothrombin gene mutation causes both first trimester and second trimester pregnancy losses, whereas your protein S deficiencies cause your second trimester losses, right? So the most common things that we come across will be your factor V laden and prothrombin gene mutation. And there is a stronger association between these thrombophilias and second trimester losses versus your first trimester loss. Going into the investigations. Have I confused you enough as of now? So what I finished now is basically the etiology. So I'm going next as to how do we detect all of this. So antiphospholipid antibodies, APLA syndrome, you detect antiphospholipid antibodies in the maternal blood. The antibodies that we detect are lupus anticoagulant, beta-2 glycoprotein, and anti-cardiolipin antibodies. You need to detect these antibodies 2 times, 12 weeks apart, and the titer of the antibodies should be more than 40 grams per liter. So, and this is done when the patient is non-pregnant, right? So, and when you detect it, you become aware and you start aspirin and heparin earlier in the next pregnancy. So this is as far as APLA goes. The role of karyotyping comes in patients with suspected genetic causes of recurrent pregnancy loss. So if there are 3 or more abortions, you send the products of conception for karyotyping. And then you karyotype the mother and the father. If there is an unbalanced translocation, or if the mother is a carrier for unbalanced translocation, there is a 5% risk of subsequent abortion. If the father is a carrier of unbalanced translocation, it is a 1% risk. If both are carriers, that's a 100% risk, right, of pregnancy loss in the future. Now, what is the use? Because essentially what we can tell them is, you might have a normal pregnancy in future, or you might have an abortion in future. That is the only thing we can. But we can help the patient it allows for an informed prognosis of future pregnancy outcomes, and the patient can decide how to move forward. So the role of karyotyping is essentially just to prognosticate outcomes in the subsequent pregnancies. I was talking to you about uterine anomalies. How do we detect them? The pictures that I put in the side is a 3D ultrasound. So this is how a 3D or three-dimensional ultrasound looks like. Now that is now almost the gold standard for detecting uterine anomalies. Now these are features which are present in your high-end ultrasound machines. So a little bit of training, you can detect them. The first picture is how a normal uterus looks like. The subsequent pictures below, you can see that the uterine cavity seems to be constricted. So these are uterine anomalies. The one to the left is an arcuate uterus, and one to the right is a septate uterus, right? For inherited thrombophilias, we screen for factor V Leiden, prothrombin gene mutations, and protein S deficiencies, because these three are the most common that are found. So we've detected. What do we do next? Again, depends upon the cause. How is antiphospholipid antibody syndrome treated? So when the patient gets pregnant again, we start her on aspirin and heparin, and we continue it throughout the pregnancy, almost till delivery. Now this has shown to improve the live pregnancy rate by 53%, right? If you do not treat APLA, the live pregnancy rate is less than 10%. So by treating them with aspirin and heparin throughout pregnancy, we increase the pregnancy outcomes by 53%. Now, it is not like you start aspirin and heparin, patient is well. No. In spite of your treatment, patients with APLA syndrome have complications. What are the complications? They are at higher risk of preeclampsia. They are at a higher risk of preterm labor. There are a higher risk of recurrent abortions, and they are at a higher risk of intrauterine growth restrictions. So knowing all of these complications can occur, we have to go ahead and treat. The problems with using heparin is given subcutaneously. Now we use what we call low molecular weight heparin as compared to unfractionated heparin. Long-term use of heparin has been associated with bleeding complications, osteoporosis, and something called heparin-induced thrombocytopenia. Fortunately, all of this is rare. Osteoporosis, we don't use it. We use it only for the duration of pregnancy and 6 weeks of delivery, so has not really been documented. But these are the complications that we have to keep in mind. Previously, they used to try corticosteroids and IV immunoglobulin for antiphospholipid antibody syndrome. They're not found to increase pregnancy rates and should not be given. So the standard of care for a patient with antiphospholipid antibody syndrome is aspirin and heparin. So genetic factors, I already told you, helps to prognosticate future pregnancies. Essentially, the outcomes or the options that should be made available to them in the case of unbalanced translocation in both the parents is gamete donation and adoption. If not, we can tell them that there is a 5% risk if the mother carries a unbalanced translocation, 1% risk if the father carries an unbalanced translocation, and let them plan a future pregnancy. Now, the role of pre-implantation genetic diagnosis arises only in IVF pregnancies. Like the previous speaker mentioned, you take one or more cells of the blastomia or the embryo and subject it for genetic analysis. So this picks up chromosomal abnormalities. The idea is to ensure that a good fetus is allowed to grow, and any fetus with aberrations is not implanted back into the uterus. How do we treat anatomical factors? I told you that septate uterus is implicated in pregnancy loss. What we do now is hysteroscopic septal resection. Many studies are not there to prove whether these are useful or not, but this is essentially offered to patients with recurrent pregnancy loss in the hope that resecting a septum will improve implantation. Open procedures are essentially abandoned because they carry a higher risk of scar rupture or uterine rupture in future pregnancies. So what do we do for patients with cervical incompetence? We offer them a surgery called cervical cerclage. I'm sure all of us remember what it is. So essentially what we do is, once we do the NT scan in the first trimester, which is around 11 to 13 weeks, 6 days. So that is the first scan done for screening of anomalies in the baby. We put a non-absorbable suture around at the level of the internal os of the cervix. So the essential reasoning is you're tightening the internal os, thereby holding the pregnancy inside, right? So cervical encerclage, it's not without its complications. The complications that can be expected is rupture of membranes and thereby expulsion of the fetus. Those with a suspected history but who have not done the cerclage can be followed up with serial ultrasound scans to look for cervical length. But those with a known history or having a cervical length less than 25 millimeters are offered cervical cerclage before 24 weeks of gestation. We don't wait till the anomaly scan, which is done at about 20 weeks. Usually, if the first trimester, like I told you, if the NT scan or the first trimester scan is normal, we go ahead with cerclage at around 14 weeks. It has been found, so in spite of all of this, what the study suggests that putting a cerclage does not essentially improve live pregnancy outcomes. There is still a risk of preterm deliveries in these patients. However, if in a routine scan done in the first trimester, you find that the cervical length is less than 25 millimeters, this is found useful in predicting preterm labor. So for those where the cervix is extremely scarred, extremely short, abdominal cerclage can be done, and it is a challenging procedure. This category forms another treatable cause of recurrent pregnancy loss. Like I already said before, a good glycemic control in patients with diabetes ensures very good outcomes. Treating autoimmune thyroiditis, normalizing thyroid function improves good pregnancy outcome. And the commonest medicine that we use in obstetrics is progesterone, because for us progesterone is sarvaloga nivarani. Anything and everything is helped by progesterone. Contrary to what we believe, that is not the case. Studies have come up saying that supplementation of progesterone or human chorionic gonadotrophin. The speakers yesterday mentioned about human chorionic gonadotrophin. It supports the pregnancy till the placenta takes over. It has a structure similar to progesterone. Now, supplementing this in the first trimester does not improve outcomes. Supplementing metformin. Metformin has been commonly used in patients with PCOS. Previously, right, left, and center. Now, the indication for metformin in PCOS is only those with proven impaired glucose tolerance. So, in the absence of that, none of these three medications have really known to improve outcomes in recurrent pregnancy loss. Now, suppression, what do I mean by suppression of LH levels? In polycystic ovarian syndrome patients, your luteinizing hormone levels are high. And this is secondary to hyperandrogenism. Now, how do we suppress LH levels is you put them through a course of oral contraceptive pills. Now, this suppresses the LH levels. Now, this has also not been known to improve pregnancy rates. Immunotherapy. This is still a gray field. Everything is immune, and we can't offer much to these patients. The experimental treatment that they have tried is intravenous immunoglobulin, third-party donor leukocytes, which are transfused into patients with recurrent pregnancy loss and suspected immune component. Now, this is not to be encouraged because it can cause adverse reactions like blood transfusion reactions, can cause anaphylaxis, and is also implicated in the transmission of blood transmitted hepatitis infection. So this is obsolete, should not be done. In patients with inherited thrombophilias, what we offer them is heparin. Inherited thrombophilias with second trimester losses have shown improved outcomes with heparin, whereas inherited thrombophilias, sorry, I have 2 or 3 more slides. Back. So this is the crowning moment in the sense that most of the unexplained pregnancy losses are unexplained. Recurrent pregnancy losses are unexplained. We really do not know the cause. And what they have shown contrary is without putting the patient through rigorous pharmacological therapy, just supporting the patient, I guess by counseling, just empathizing with the patient per se improves the pregnancy outcome. So essentially a hands-on, hands-off approach helps these patients. And they have they have proven that there is a 75% chance of successful future pregnancy with supportive care alone. And the prognosis becomes poor, as mentioned, if the maternal age is higher and if there are unexplained pregnancy losses are being put under aspirin and heparin, though the live birth rates have not been improved in the sense that you cannot prove that it is APLA. You really do not know what you're dealing with. So these patients are put under heparin and aspirin, but this is not shown to improve live birth rates. So to conclude, most of the causes of recurrent pregnancy losses is unexplained. Genetic counseling plays a major role if unbalanced translocations are detected. Balanced translocations are essentially innocuous. You really do not have to worry about them. Treating endocrine disorders like diabetes, PCOS, and hypothyroidism improves outcome. Combination of aspirin and heparin form the keystone of treating APLA. There is no role for torch screening and immunotherapy in recurrent pregnancy loss as of today. Progesterone supplementation using metformin or human chorionic gonadotropin does not improve birth rate in patients with recurrent pregnancy loss. And heparin may improve fetal outcomes in women with second trimester. Patient listening.
Thank you, ma'am, for that enlightening presentation. Now, the forum is open for discussion.
Thank you, Dr. And especially as an OGCN to prepare the slides and present as well. We are used with it. And it was an excellent presentation. And once again, thank you.
Yes, ma'am. Ma'am, like you said, 1 to 2%, ma'am. They're not very common, thankfully. But when detected, if we have a treatable cause, like antiphospholipid antibody syndrome, which is probably the most common, we are able to give good outcomes. But genetics, unexplained, is essentially difficult to treat.
I think all these investigations, etc., I mentioned are the recent advances, isn't it? Maybe
they have been there in time, but the recent advances is we moved to 3D ultrasound now for uterine anomalies. Previously, we were doing MRIs. 3D ultrasound forms easier or a cheaper modality as compared to an MRI in detecting uterine anomalies. APLA syndrome has been around for some time. Inherited thrombophilias are fairly recent, and I think what is being more stressed or more researched upon now is the genetic causes and immune causes, though they haven't really come out with proper treatment protocol. We do not know what we do if we detect it. That is a problem now.
Long back when I was working in a gynae nursing home before my post-graduation, it can be a very vexing problem. Like
Yes.
one patient who said torch infections has got no role to play, and that was the one which was tested. I do not know whether any other investigations was done. And the patient was really very vexed up, and she said, like, she gets pregnant, but she's not able to sustain the pregnancy.
What we see more commonly is we have third gravidas. They have previous two abortions, but the third is the lucky number, so they do carry that. The problem comes when it is more than 3, though we start investigating them when there is a second loss itself. Now, the problem with torch is you'll have a panel of IgG results, a panel of IgM results. How are you going to interpret it? That is a problem. We say IgM na recent infection, IgG na either. Treatment, whether treatment really improves outcome. But the main reason we've given up on torch is because it does not persist. Torch is not there anymore in the panel of losses, though many still do it.
Thanks, Divya, for the beautiful lecture.
Thank you.
Good morning. Good morning, madam. Madam, I want to know whether the placental insufficiency can be identified.
Yes. How do you detect placental insufficiency? It translates to intrauterine fetal growth restriction. So when the placenta is not working properly, the perfusion to the baby gets affected. So essentially, the fetal growth parameters start reducing. We look for a fall in the abdominal circumference in the baby, and then we look for Doppler studies. Now, IUGR is revolutionized by the use of umbilical artery Doppler, middle cerebral artery, and ductus venosus. So that is what we do.
Madam, we said if we have the hypercoagulable state, we start with heparin and
Yes.
aspirin. How do we assess whether that treatment is sufficient for the fetal care?
Sir, there are standard protocols in place. Aspirin, we go up to 150 milligram. And aspirin is not only indicated per se in thrombophilias. Now we start low dose aspirin on patients with previous history of pregnancy-induced hypertension. So there are multiple criteria by which we go. And studies have shown that it is fairly okay in pregnancy. It really does not cause any fetal teratogenicity, and the mothers tolerate it well. Heparin, essentially, it depends upon the maternal weight. So that is essentially what we go. So is there an individual? So these two are the cornerstones, but do we individualize care for every patient? No.
Okay. We know that the endometrial thickness is very essential for the implantation process to take place. So pre-gestationally, do we have any idea on, personally, from your experience, do we have any idea on the thickness of endometrium, and can we assess that it can lead to, the low thickness can lead to a recurrent fetal loss?
Essentially, the growth of a follicle and the endometrial thickness indirectly relates to the quality of the oocyte. So the oocyte is good, then the hormonal milieu is essentially normal. So endometrial thickness is not essentially taken as a criteria for implantation, because we really cannot study implantation. We know that the embryo implants, but what are the factors which improve implantation has not yet been studied. So I think these are areas of research, which is why there is this thing called unexplained infertility, which is still unexplained. We don't have the answers. So in endometrial thickness, we say a minimum of 8 millimeters is enough. But we do find patients where they have a good endometrium, where we find this trilaminar pattern that we look for. They still don't conceive. So there are other factors in play which have still not been diagnosed.
In your experience, have you come across a mother giving the same history like a child with recurrent pregnancy loss?
No, sir, I haven't.
I'm not going to ask any question, but it's a wonderful presentations. You have covered almost all the aspects, including cytogenetic analysis, cervical incompetence, and some of the hormone supplements. So, congratulations on the presentation. And even yesterday, I observed in some of the sessions, the discussion involved was amazing, really.
Thank you. Thank you so much for your kind words. Thank you.
Not as an observer and not as a dean, but as a gynecologist, I want to tell. Still, the question he has asked, the pre-implantation endometrium. Now there are many papers which say that protein-rich plasma improves the endometrial thickness and aids in implantation, but nothing is proved. It's only the company people who are promoting. Actually, I tell you, because generally when there is a as she has told, trilaminar structure you see, you expect the endometrium to be ready for implantation, one thing. So protein-rich plasma, even we can try. It's still in the research only. And about touch, still, as she says, it is not rich in the vaginal flora or in the endometrium, but cytomegalovirus and herpes simplex 2 has been proved to be causing many damages. So it can affect. And there is no, I think there is no harm in IgM is positive. Because previously we didn't have any patients with rubella positive even. Because rubella is not known as such in our side. After the influx of Sri Lanka refugees, the incidents have gone up a lot. Because the rubella is very rampant in Sri Lanka. And now when you test for your patients, just as a test when you do for touch, you find there are many people who are IgG positive for rubella, which was not previously there. So the milieu is always changing. And very sorry to say, whatever Western people say, we will say yes. Whatever is found out in India, we won't accept. எப்பயுமே நம்ம வீட்டுக்குள்ள இருக்கிறது நமக்கு பிடிக்காது, அடுத்தவங்க தான் சொல்லணும். அதே மாதிரி ஐ எம் சாரி டு சே ஆல் கைனகாலஜிஸ்ட் நோ தே வில் கெட் ஒன்லி ஒப்பீனியன். யாராவது ஒரு மேல் மெம்பர் வந்து அது இதே இப்ப சொன்ன இதே ஹெப்பாரினையோ இதே ஆஸ்பிரினையோ பேஷண்ட் போடு அப்படின்னு நம்ம இன்ஸ்ட்ரக்ஷன் கொடுத்தோம்னா நம்ம பிஜி நம்ம அசிஸ்டன்ட் நம்ம எங்க ஜெனரேஷன் போட மாட்டாங்க. மேடம் நியூராலஜிஸ்ட் வந்து லோமாலிகுலர் ஹெப்பாரின் போட சொன்னார் மேடம், ஏன் அதை நாங்க சொல்லும்போது போட மாட்டீங்களா? ஸோ அந்த மேல் ஷாவனிசம் அண்ட் இந்த ஃபீமேல் என்ன சொல்றது, இது வந்து தட் இஸ் தேர் எவ்ரிவேர் ஐ ஹவ் சீன், எஸ்பெஷலி இன் ரிச்சியஸ் ஆரம் மோஸ்ட் rampant. So definitely aspirin, as she said, actually preconceptional aspirin they advise if apply is positive. Preconceptional itself, as how you start folic acid as an engagement pill. Like that, if the apply is positive, if you start them on low dose aspirin of 75 milligram per day, definitely it improves the pregnancy rate. You can't say that it's not improving. Of course, HCG, progesterone and all, I have experienced even without giving anything. If you approach the patient with empathy and say, you are very well and your baby is very well, they accept it. And even without any hormones, the pregnancy goes up to term. Thank you, Diya.
Thank you, ma'am. And on that note, rubella.
Really, it is a reasonable and a must compartment.
Rubella vaccine is available. It's a live vaccine. So taking that vaccine and not getting pregnant for at least 3 to 6 months, I think will prevent rubella infections. Fortunately, torch infections are rare. But I thank Madam for opening my eyes on the other perspective also. So thank you all for your patient listening. And thank you for giving me this opportunity. Thank you.
Thank you, ma'am.
Is there any relation with the history of contraceptive, hormonal contraceptive use and aspirin?
No. None proven as of now. No.
And also, is there any role for bed rest and all those kinds of things?
Exactly. No, that depends upon the cause. So essentially, if you have a patient with severe hypertension, we don't want her walking all over the place. But undue bed rest is not advised in any of the known causes of pregnancy losses. I think it's a trap essentially because the patient take too much of rest and they put on weight and obesity becomes a problem. So I think we need to keep reassuring the patient that things are okay, that we're doing the best we can for her. That's the only thing we can do.
Okay, thank you.
Thank you, ma'am. We invite
just
Madam, you said about the Doppler test in the uterine arteries. What causes change in flow? In some people, it's low. Why?
No. There are two different things. We're talking about the uterine artery and the umbilical artery. Now, uterine artery is essentially used as a predictor for pregnancy-induced hypertension. So we do that Doppler in the first trimester with the NT scan and around 20 to 24 weeks. So if you have a higher pulsatility index, what do I mean is the uterine artery has good flow during systole and diastole. It has to have, because it is going to be, supplying the placenta, and the baby has to be nourished throughout the cycle. Now, when there is increased resistance, what it translates to that there might be compromise in the blood circulation to the baby. So the uterine artery is more for protection. For following up growth restricted fetus, we go with the umbilical artery and the middle cerebral artery Dopplers. So essentially, which means that if there is a reduction in flow, it translates to something called an increased end-diastolic resistance in the uterine artery. So we take it from there.
What's the role of aspirin?
Now, why does the cause of uteroplacental insufficiency is there are two waves of trophoblastic invasion. So trophoblastic is essentially forms the which is, you can say, which is the in the important unit of placenta. Now they have to invade into the uterus enough to establish a proper circulation, which translates again to better flow to the baby. So when this invasion is limited for whatever reason, it causes uteroplacental insufficiency, right? So aspirin, by being an antiplatelet, prevents the formation of thrombosis in these small vasculature, thereby improving flow.
And I hope it is stopped by the time the
which is why we started way early, because the second wave finishes by around 16 weeks. So there is no point in starting aspirin later. So we need to start aspirin way earlier.
Thank you so much.
Yeah, thank you.
Thank you, ma'am.
And we stop aspirin by, studies are coming up where they say stop aspirin by 36 weeks, right? So but there are also studies which says if you take the patient up for delivery, even when she's on aspirin, there is blood loss is not very much. So essentially, aspirin is something which is cheap, and it is definitely known to improve pregnancy outcomes. Yes. Thank you.
Thank you, ma'am. We invite Dr. Vijay Devanand to felicitate Dr. Divya Seduraman ma'am with a shawl. Thank you, ma'am. We invite Dr. Keetna to felicitate ma'am with the memento. Thank you, ma'am. We invite Dr. Renuka Devi ma'am to felicitate ma'am with a gift. Thank you, ma'am. We invite Dr. Sembalingam sir to felicitate Dr. Vijay Devanand ma'am. Thank you, sir. We invite Dr. Sudha from Government Medical College, Karloor to felicitate Renuka ma'am. We invite Shanti ma'am to felicitate Dr. Renuka. Thank you, ma'am.
I am sure we all need a little break from the influx of valuable information that we've just had. So please take this time to socialize and have a small tea break in the food venue just outside the auditorium. We'll continue our session in 15 minutes. Thank you.
நீங்க போங்க சார். போங்க சார். ஆல் பிசியாலஜிஸ்ட் டுகெதர். போங்க சார். நிகில் போ. அந்த photo இல்ல, ஆடா, நீங்க எல்லாரும் எடுக்க மாட்டாங்க.
எல்லா சைட்லயும் எல்லா போட்டோவும் நம்ம படிச்சுட்டு போகல அதெல்லாம் மத்த நல்ல யூடியூப்
அப்படியே வாங்க வாங்க.
டீல் எடுத்துறீங்களா? திவ்யா, வெரி ஹார்ட் ஒர்க்கிங் தெரியும்
சார். எனக்கே ஸ்டூடெண்ட் தானே சார்.
only one. அது தெரியாது. இல்ல, இல்ல. ஆமா.